A very good evening to all the respected dignitaries, seniors, colleagues, experts, as well as speakers on Zoom as well as YouTube Live. Welcome you all on behalf of Maharashtra Academy of Pediatrics and MahaIP Women's Committee for today's program of Tuesday Take. Tuesday Take is a unique concept program with topics of our daily OPD practices. And here we have 5 speakers from different zones of Maharashtra, allotted with 5 different topics, 8 minutes for each speaker to present, and we have 1 expert for guidance, who will give his expert opinion after each topic. Viewers, please note today's program has been allotted 1 MMC point, and so requesting everyone to please type your name, city name, central IIP, and MMC registration number in the chat box. I, Dr. Neha Singh, MahaIP, Women's Committee Co-Chairperson and practicing pediatrician from Navi Mumbai, Raigad district, as well as my co-host, Dr. Shilpa Dudhgavkar, President, Pune IIP, Senior Consultant at Jahangir Hospital, Pune, Director, Srinivas Hospital, and Zonal Member of MahaIP Women's Committee for West Maharashtra. We both are the moderators for today's Tuesday Take. Now I welcome and request our MahaIP President, Dr. Ramakant Patil sir, to kindly give his blessings. Over to you, sir.
Thank you, Neha. And it's really heartening and gratifying that the Tuesday Takes are being taking place continuously. And more heartening is to see that the young guns, all speakers are less than 40 years. It is really a Yuva webinar being conducted every month in a Tuesday, on Tuesday, one Tuesday in a month. And every time the new topic, which is very useful to practicing pediatrician, is being taken. And I appreciate the women's wing and all the AB members of MahaIP steadfastly working for all the MahaIP activities for Presidential Action Plan. I mentioned the presence of our immediate past President, Dr. Hemant Gangolia ji. Today's the guide and who is who will be guiding all the speakers, Professor Dr. Subbarao, N.K. Subramaniam, and moderators, particularly Dr. Neha and Dr. Shilpa. And more important are the speakers and from the different corners of Maharashtra, Dr. Soumya, Dr. Amol, Dr. Siddhant, Dr. Bharti, and Dr. Yogesh. And very practical topic is being taken. And I hope that full dress rehearsal must have been done, that the exact to the point message will be delivered across the thing for as the delegates are most important part of all these webinars, and it will be useful for all practicing pediatricians. So once again, congratulating the women's wing of MahaIP and particularly Dr. Neha, Shilpa, Manjusha, and Women's Committee Chairman, Dr. Shirbate, Sonali, and our secretary, who is having relentless energy to conduct all the activities simultaneously, and all the delegates and panelists for being present over here. Over to you, Neha. I wish all the best for coming Tuesday Takes also and for today's session also.
Thank you, President sir. Now I request our MahaIP Secretary General, Dr. Amol Pawar sir, to give his blessings. Over to you, sir.
Thank you, Neha. Good evening, Dr. N.K. Subramania. Good evening, Dr. Hemant Gangolia sir, Dr. Ramakant Patil sir, Sonali ma'am, and all the speakers of today Tuesday Takes and all delegates and PG students who have joined from all over Maharashtra. This is a very nice concept by Women's Committee, which was formed last year. And last year also we conducted almost 11 Tuesday Takes sessions. And this year also we are on the way of conducting 10 to 11 Tuesday Takes sessions. And the speakers are chosen by Women Committee, Zonal Women Committee members from all the 5 zones. And they are, as President sir has already told, they are young, dynamic, and they are ready to go for today's Tuesday Takes. So without wasting time, I give all the best to all the speakers. And thank you, Neha, for your words.
Thank you so much, Amol sir. I welcome Dr. Sonali Shirbate ma'am, our MahaIP Women's Committee Chairperson, to say a few words. Over to you, ma'am.
Thank you, Dr. Neha. We are really very fortunate that today we have our expert, Dr. N.K. Subramania sir. Is very well known in the, especially today's theme is respiratory system. And most thankful to for the guidance of our president, Dr. Ramakant Patil sir and Dr. Amol Pawar sir. Because of them, we can move in every further in every session. As well as I'm very thankful to Dr. Neha, our today's coordinator, Dr. Shilpa madam, and my all zonal EB members, Dr. Mangai, Dr. Grivita, Dr. Shilpa Dudgaonkar, Dr. Nivedita Patil, Dr. Pallavi Patil, Dr. Manjusha Giri, Dr. Swati Patil, Dr. Sucheta Pofre, and Dr. Dipti Deshmukh for their participations and for these speakers. So let's move further. Over to you, Dr. Neha.
Yes, thank you, Sonali ma'am. Dr. Rajendra Kulkarni, Senior Pediatrician from Nashik, is our MMC observer for today's program. Has he joined? Pallavi ma'am?
Not yet, ma'am. Not yet.
Okay. As soon as he will join, we will have his comment also. So we move forward. Today's theme is for Tuesday week is respiratory system. And who can we think more better than our expert for today, Dr.
Neha, actually, Dr. Rajendra Kulkarni sir has joined.
Okay. Rajendra sir, can you unmute, sir?
Actually, he sent WhatsApp message.
Pallavi ma'am, have you unmute Dr. Rajendra Kulkarni sir?
Ma'am, I have given the permission, but his name is not like in the list.
He's in Europe actually.
Okay.
Okay,
sir,
we'll continue.
Yeah, his name is not like visible here in the list.
We'll continue, please.
Yes, sir. Yeah, thank you.
Thank you, Rajendra sir, for connecting from Europe at this time. Now I welcome Dr. N.K. Subramania sir, our expert of today. He has accepted our invitation for joining today in Tuesday Take and guiding all the speakers and all of us. Now I hand over to my co-host Dr. Shilpa to introduce our expert and then further the proceedings.
Good evening. Thank you, Neha, for that wonderful introduction. Without wasting any time, I'll introduce the first speaker. She is Dr. Soumya Alukuchi. She is from IIP Palghar. A short introduction. She's a consultant pediatrician at Ananya Eye Care and Children Clinic at Meera Road. And today she's going to talk on a very important subject, that is cold and cough medications, which we routinely prescribe. So let's see what she has to tell us about the cold and cough medication. So over to Soumya. I think you can take over from here.
Yes, ma'am. Thank you for the introduction, ma'am. I'll be just sharing my screen. And good evening. Good evening, everyone. Good evening, dignitaries of Maha-IAP and Maha-IAP Women's Committee and respected judges, moderators, and co-speakers. So I am Dr. Soumya Alukuchi. I am representing IAP Palghar in this session, and the topic given to me is cold and cough medications. So cold and cough medications are the bread and butter of pediatrics practice. So as pediatricians, we hold the responsibility of diagnosing and prescribing the correct medicine for a correct situation. So common cold is an acute viral infection of the upper respiratory tract characterized by rhinorrhea and nasal obstruction with associated features like headache, myalgia, and fever, which can be mild. Whereas cough is a sound produced by an attempt to expel an irritant during forceful exhalation, but this term is often misinterpreted by parents as noisy breathing or vibratory feel on the chest or mucus spitting in the vomitus. So common cold is in more than 50% of the cases is caused by rhinoviruses, but other viruses which are responsible are respiratory syncytial viruses, influenza and parainfluenza viruses, and coronavirus. And it spreads by direct hand contact, small particle aerosol inhalation, and large particle aerosol inhalation. So viral infection of the nasal epithelium leads to acute inflammatory response in the nasal mucosa, resulting in nasal congestion and discharge. So the treatment of common cold is mainly supportive. Though antiviral medications like ribavirin, which is used in severe respiratory syncytial viral infections, or oseltamivir and zanamivir, which are used in influenza-associated illnesses, and These medications need to be started within 48 hours of the symptom onset. Hence, the pathological organism isolation is very important in these cases, and there is no specific antiviral therapy available for rhinoviral infection. And antibiotics are used in specific situations where, as in complicated cold like otitis or sinusitis. The supportive care of common cold contains adequate rest and oral hydration and ingesting warm fluids. Children are deliberately mouth breathing because of the nasal congestion and blockage. Hence, the throat is supposed to dried up, and there is a thickening of the secretions, which is difficult for them to expel. Hence, ingesting warm fluids and keeping the hydration at adequate point will help in pharyngeal hydration and thinning out the mucus and help them remove it successfully. So topical nasal saline drops, which contain 0.65% of the sodium chloride and benzalkonium chloride as a preservative, they can be put in the, 1 to 2 drops in each nostrils to relieve the congestion, and they can be used even in neonates. And saline irrigation can be used in older children also. And vapor rubs, which are applied on the chest and the back, they give the sensation of opening up the airways, but actually spirometry doesn't show any improvement. And warm mist or cold mist humidification or inhalation is not recommended by WHO, though some of the articles show improvement in breathing with warm mist inhalation sometimes. So antipyretics or mild analgesics like acetaminophen or paracetamol can be used to combat with associated features like headache, myalgia, or fever. But in case of children where they are irritable because of the cold, using paracetamol on a regular basis for 2 to 3 days for the initial period of the illness is required. So topical adrenergics like oxymetazoline or xylometazoline or phenylephrine, like they are available in 0.1% and 0.05% strength formulations. They act by causing vasoconstriction of the nasal mucosa. Their prolonged use can cause rhinitis medicamentosa, which is a rebound sensation of nasal congestion due to the sudden withdrawal of the drug. So, and their prolonged use can cause persistent vasoconstriction resulting in atrophic rhinitis also. Hence, their prolonged use is not recommended definitely, and they are not recommended for children younger than 6 years who cannot tell their what they are feeling. And first generation antihistaminics like chlorpheniramine, they can be used for rhinorrhea due to their anticholinergic effect and not their antihistaminic effect. Whereas second generation or non-sedating antihistaminics, they have no role because they don't have anticholinergic activity. Hence, they are not supposed to be used in viral upper respiratory tract infection unless it is allergic rhinitis. And they are associated with side effects also like sedation and paradoxical hyperactivity, whereas oral adrenergic agents are less effective than topical preparations, and they are also associated with side effects like CNS hyperstimulation and hypertension, etc. And combination of antihistamines plus decongestants are widely used in pediatric practice, but they should better be avoided in children below 6 years of age. This, as the old saying goes, cold is treated with medicines in a week and without medicines in 7 days. It still stands true. Coming to cough, we should inquire the parent if the cough is a predominant symptom and it is dry or wet. Is it recurrent or is there any family history? And characteristics of cough, whether it is worse at night or onset of the cough is sudden or over a few hours, and progress of the cough and sequence of appearance of symptoms to come to a proper conclusion so that we can prescribe appropriately. So the drugs used in cough are classified into demulcents, expectorants, antitussives, and adjuvant antitussives. Demulcents like honey or lozenges or cough drops, they soothe the throat mucosa, pharyngeal mucosa, and reduce the afferent cough impulse to the cough receptor, and they reduce the strength and frequency both. Hence, they are helpful. Like honey can be used in children above 1 year of age, and cough drops can be used in children more than 6 years of age, where there is no risk of foreign body aspiration. And expectorants, which increase mucus secretion, and mucolytics, which thin out the mucus, they are used where we suspect thickening of the mucus, and it is difficult to expectorate, as in situations like pneumonia where there is wet loose cough, or in bronchiectasis or in cystic fibrosis, expectorants are helpful. Antitussives which are centrally acting like dextromethorphan or codeine, they increase the threshold of the cuff center for the reflex, and peripherally acting antitussives like levodopa or levocloparastin, they decrease the tussle impulse itself from the peripheral cough receptors, and antihistaminics act by sedation and not by acting on the cough receptors. And adjuvant antitussives like bronchodilators, they help by dilation of the bronchi and bronchioles and decrease the cough in specific situations. So treatment of cough in specific situations, the viral upper respiratory tract infection, it can be treated like cough caused by viral upper respiratory tract infection is treated by honey or mild sedative like chlorpheniramine, or peripherally acting antitussives like levodopa or levocloparastin. So we should consider the age of the child and prescribe these medications. And bronchiolitis or wheeze-associated lower respiratory tract infections or asthma, inhaled bronchodilators are preferred. And whereas in acute infective cough, such as in acute pharyngitis or pneumonia, appropriate antibiotics are prescribed. And in bronchiectasis or cystic fibrosis, where thick mucus secretions are there, expectorants will be helpful. And for dry irritant cough, antitussives like dextromethorphan, levodopa or levocloparastin can be used. So centrally acting antitussives will cause drowsiness and respiratory depression, especially in children. And fixed dose combinations of bronchodilator or antihistaminic with antitussives they cause high atropinic activity. We know an incident from Mumbai where a 2.5-year-old child went lifeless after consuming a syrup containing chlorpheniramine plus dextromethorphan. He has a grandmother who is an anesthesiologist, and she could perform CPR on him for 17 minutes straight to revive the child. Everyone is not that fortunate, hence we should be careful while prescribing such medications. And fixed dose combination drugs are not satisfactory because of their difference in the half-life, and also they act on different types of cough. Like expectorants is for wet cough, and dextromethorphan is for dry cough. So we cannot combine. We should see a particular cause and we should prescribe accordingly. And bronchodilators will cause muscle tremors or palpitations or restlessness, etc. And coughing in infants is usually uncommon, and we hence need to rule out serious illnesses like congenital heart disease or gastroesophageal reflux, or aspiration secondary to congenital malformations like tracheoesophageal fistula or cystic fibrosis if coughing in infants is significant. So to conclude, we have cetirizine and levocetirizine has no role in viral URTI. They are helpful in allergic rhinitis. And the products containing montelukast is though safe, it is used as an adjuvant to inhaled bronchodilators in persistent asthma, but not as a treatment for common cold. And irrational fixed drug combination need to be avoided, as I have already told. We should see the cause and prescribe accordingly, and not as a combination drug. And age cutoffs for these drugs are like cetirizine and fexofenadine should be avoided in children below 6 months of age. Honey should be avoided in children below 1 year of age due to the risk of botulism. And levocetirizine and montelukast are not used below 2 years. Antitussives are avoided below 4 years of age. Antihistamines, decongestants are avoided below 6 years of age. So to conclude, we have to counsel more and prescribe less, and supportive management for cold and cough is the key. And over-the-counter cough and cold medication use should be discouraged by pediatricians, and home remedies help reducing the symptom severity, if not the duration. We should warn the parents about the red flag signs like breathlessness, retractions, or high fever or persistent cough. But cough in infants needs evaluation and proper management. So with this, I conclude, and I thank you, and I thank MAHA-AP and MAHA-AP Women's Committee to give me this opportunity. I have mentioned a few drug dosages to go through with, if at all anybody needs. So thank you, ma'am.
Thank you. Thank you so much. Now from your talk, we have really differed some nice conclusions. Zanamivir, which is used, I don't think it's very easily available all over. I don't know what is the experience of the other seniors, You said a very nice thing about no role of non-sedative antihistaminics. I think that's a very nice pointer to everybody out there who is listening. And another take-home message is about the fixed drugs. So you did a great job. Thank you so much. I think we'll proceed to the next speaker. The next speaker is Dr. Yogesh Shivay. He is from IIP Buldana, and he's going to.
Shilpa ma'am, sorry to interrupt. We will have our expert opinion after this.
Fine.
Subbu sir, please.
Yeah. Shilpa is also an expert, so it's all right. She actually made nice comments. She is also part of our respiratory group. And I don't think I have heard a better talk on cold and cough. Soumya, hearty congratulations to you. Personally, this is very lucid and very crisp and clear messages on cold and cough, which forms more than 60 to 70% or more than 3/4 of our practice. One should be very clear. The problem with most of the pediatricians is they try to treat the symptoms, not the disease. This is the first point that they have to understand. Don't treat the cold, don't treat the cough, treat the disease causing them. And most of them, the disease is self-limiting and benign, which needs to be understood. Therefore, the drugs have got very less role. And those drugs are called as symptomatic drugs, and they are not disease modifying. Regarding colds, I have got only one message. The colds in the young infants is often more a block than a discharge. Do you all agree on this point? Newborns, 3 months, 6 months, it's more a block that is a problem rather than a rhinorrhea. And therefore, you need to use nasal drops, which are saline nasal drops, which are 0.65%. Don't use normal saline, which is available in the intravenous fluid, or salt water preparations, homemade, etc. Don't try anything new. The prescribed normal saline nasal drops available in the market is a buffered solution with benzalkonium chloride. So therefore, it's excellent, soothing, and non-irritant. And there will be a lot of crusting, thick mucus, blockage, etc., which will be cleared by after applying to normal saline nasal drops. The nasal toilet has to be taught to the mother. She really, sometimes they do not know what is to be done, and this is very, very important. The second drug that is most important in treatment of cold is paracetamol in absence of fever, because the paracetamol reduces irritability, body ache, headaches, and symptoms associated with the cold. Suppose a child with cold is crying more, maybe because of use taken block also, may not be otitis media, but when you give paracetamol, the irritability comes down. Often these children are crying and panic. We tend to push antibiotics, but not good antipyretic. Or I would say analgesic rather than an antipyretic. Here, paracetamol is used as an analgesia. Please, normal saline nasal drops, and these are very, very important. My third message is, in the cold, in the older children, there are 3 phases. Rhinoric and congestion phase, which lasts for first 2 days. All of you recollect your colds. First day you feel stuffy, block, and you sneeze, and you feel little warm, mild, feverish, and you will have some prodrome symptoms. Do you all agree? First 2 days. And the next 2 days you will have discharge, block, and typical by this, then the fever will be there and goes down, and then symptoms continue. 4th, 5th day to 7th, 8th day, you will have thickened secretions. That time you will really want it. Your acute symptoms and prodromes develop, all of them have gone. Only local nasal symptoms will be there. My only message is, if you use first generation antihistamines, which I'm not recommending, suppose if you are using off-label first generation antihistamines, which you are forced to use in your office practice, it is very useful in first 1/3 phase of the cold. That is when congestion is there, sneezing is there. That exactly, Dr. Soumya, you are bang on target for anticholinergic properties, not for antihistamine properties of the first generation antihistamine. That is when, the rhinorrhea goes down by 33%, the stuffiness comes down, the child feels better. But if you continue the same medications for 1 week, and if you are in the last phase of the cold where there are thickened secretions, antihistamines will do worse, because already the secretions are thickened and they become further dry and crusting will be there. That's when the children will become irritable. So therefore, my yes to prescription in the early phase, my no to changing of prescription. Some, let's say Amol has prescribed some medicine and another Amol doctor, Amol Deshmukh wants to change from Amol Pawar to Amol Deshmukh. We don't agree change of prescriptions. At least be rational and be also give the correct dosages. Don't give overdosage. More cold, full spoon, less cold, half spoon. And suppose you don't want to prescribe 1 or 2 drops, these kinds of advices have to be avoided. If you are giving antihistamine, calculate the dose of antihistamine. Most of these drugs are not by kilo body weight. Please remember by age. There's a table of age which we will share in the Maha IAP. Soumya, please, whatever tables you have done, share it in the WhatsApp groups of Maha IAP. So
Sure.
let them see the sheet by age. The biggest mistake, lastly, sorry for time, second generation antihistamines like cetirizine, levocetirizine, etc. are used for common cold, not for allergic cold, is a common mistake. This is the take home for cold. And for cough, give me only 30 seconds. Don't treat acute cough, treat the cause of the cough. Most of the acute coughs need not be treated. Very, very important. And a cough is more not in the first 3 or 4 days of illness. Cough really starts barking on 4th, 5th, 6th, 7th, 8th day. Cough is maximum on 8th and 9th day of the cold and will resolve by 15 days. Please remember. So the peak of the cough is in end of the week. Therefore, mothers don't come to you for colds because they give medicines at home. They really come to you for the cough. And that's when you prescribe the medicines for cold for the cough. You don't require an antihistamine for the cough unless the rhinorrhea is the cause of the cough with a postnasal drip. That's a different scenario altogether. So therefore, for cough, if you find that there is risk factors for asthma in that child, please go ahead and prescribe bronchodilators, salbutamol, terbutaline, etc. Let's say I have got an atopic child, no asthma, but the child gets a cough. Did you understand what I meant by that? I am having atopy. My father is an asthmatic. My mother is asthmatic. Child is having only seasonal cold and cough. Sometimes it responds to bronchodilators. Please use them. Don't you again use the combination. Suppose that a child is having again same, but only cold, but no chest congestion. Only upper respiratory symptoms, you can prescribe even here second generation antihistamines. That is, I'm telling, not in the first week, but in the second week prescription. No medications will help in post-infectious cough, which is the commonest cause of cough. That means to say, I'll sorry, another 15 seconds for me. If suppose, Soumya, you drink hot water and you burn your mouth. Somebody serves you hot tea jealously and you burn your mouth. Please tell me when the burning is more, during sipping up of hot water or post sipping? It is post sipping. That means after an illness is gone, the respiratory epithelium is dry, raw, and damaged. And therefore, the underlying cough receptors are exposed. That is when it is most irritable. So this cough is cough of irritation due to infection. It will not respond to antitussives. It will not respond to bronchodilators. It will respond to only counseling. You have to tell them it is benign and give them the examples. Suppose you burn your mouth. If you keep ice cream, will you be fine? No, for a few seconds. If you keep honey, will you be fine? No. You do ha, ho, and all these things. Will you be fine? Answer is no. You have to be counseled that whatever you do is for short period of time. Therefore, don't prescribe round the clock syrups for majority of them and give them the assurance. Especially make sure that the cough is not part of the infection. Cough is post-infection. For whooping cough, only Pashupati should help you, because there are many very common question asked to me in many conferences. No cough medications for whooping cough. There you have to counsel the parents. And if there are questions, we'll take them in the end, because this itself will become a lecture. So these are some of the useful tips for cold and cough in day-to-day practice. I will now mute myself. You can go to the next.
Thank you, Dr. Subramaniam. I think we'll go on to the next talk.
Sir,
Is by Dr. Yogesh Shevai. Yes.
Dr. Rajendra Kulkarni sir from Europe, he has joined. He is a
Wonderful. I think
MMC observer and senior pediatrician, past executive body member of CIP. Rajendra sir,
yeah,
please
we'll
unmute and
Yes. Hello.
yes sir.
Can you hear me, Amol?
Yes,
Yes,
sir. Yes,
sir,
sir.
we can.
Yes, please continue.
Sir. Okay.
Yeah, Raja,
Okay.
I cannot
Okay.
hear you. Your
Yes.
JR here. Oh.
Hi, Subbu. I was patiently listening to you. It was always pleasure to listen to you, whether it is academic or non-academic. So, and I learn. I must tell you, I learned many things from you. As you always say that you learn pediatrics from me, but nowadays I am learning everything much more every time I listen to you here, and it's very happy and heartening to see that my colleague, my JR, my friend Subbu has become a so much sought after faculty in respiratory pediatrics. So it's very pleasant, and I must congratulate Maha IAP for this wonderful webinar, Tuesday Text, and I must thank MMC, our Maharashtra Medical Council, to appoint me as observer, so that I can listen to big faculties like you, Subbu, and rejuvenate the friendship. Okay, please carry on, and I wish my IP all the best. Thank you.
Thank you.
Thank you, sir. Thank you.
Yeah.
Shall we proceed, Amol? Okay. So I'll briefly introduce Dr. Yogesh Shevare. I think this is the third interruption, Yogesh. Now you have to go non-stop for the next few minutes. Okay. He's from Buldana. He's Director Bal Gopal Hospital and Critical Care Center, Buldana. And today, again, he's going to talk on a very important topic, is empirical antibiotic in a respiratory tract infection. Over to Dr. Yogesh. You can start your talk.
Good evening, everyone. Am I audible?
Yes.
Yeah. Topic for today's discussion for me is empirical antibiotics in respiratory infections. Empirical itself is a misnomer in context with the antibiotic use. No one could 100% judge organisms, but at least a good thought process is what is expected. Antibiotics are really not antiviral, and irrational use is real future hazard of antibiotic resistance. We have to stop antibiotic abuse somewhere. Respiratory infections consist of rhinosynovitis, pharyngotonsillitis, otitis media, and pneumonia. Rhinosynovitis is a very common problem, almost 3 to 8 episodes of viral cold per year, and they are usually self-limiting and they require only supportive care. Amongst bacteria, Streptococcus pneumoniae, H. influenzae, Moraxella catarrhalis are common organisms. And for the fear of worsening, the antibiotics are prescribed in such cases. In less than 2 years, drug of choice is amoxicillin, and if the resistance is suspected, then we can increase the dose to 90 mg per kg. These new CLSI guidelines are there. I will be talking about it later on. Is alternative in allergic patients only, and only there is a role of azithromycin, cefodoxime, cefdinir, and cefuroxime. Otherwise, amoxicillin is the drug of choice in all these scenarios. Streptococcal pharyngitis is uncommon below 2 to 3 years of age. It's a disease from 5 to 15 years age and spread by close contact. Tonsillar and pharyngeal exudates, the likelihood of bacterial pharyngitis is 50% if 3 of the following features are there: fever more than 100 degrees Fahrenheit, tonsillar swelling or exudates, tender cervical lymph nodes, and absence of cough. Common causes of pharyngitis are viral only, and bacteria consist of less number of organisms, less number of etiological agents. Antibiotics in pharyngotonsillitis, specifically group A beta streptococcal pharyngitis, is still penicillin group of antibiotics, and amongst that, amoxicillin is the first line or first choice. For individuals who are allergic to penicillins, then and then only we should consider azithromycin, clarithromycin, and other cephalosporin group of antibiotics. In acute otitis media, which consists of otitis media with effusion, acute suppurative otitis media, CSOM, which is characterized by ear pain and tugging, mere thinking that there is otitis media on the basis of just clinical examination without putting the otoscope is very crude method to judge whether it is acute otitis media is there or not. Acute otitis media is less likely to resolve spontaneously in age group less than 2 years of age, and antibiotics are used here to avoid the complications. The indications of antibiotics in acute otitis media are children less than 2 years of age, children more than 2 years with severe infection, acute otitis media with perforation, children at risk, high risk of complications like immunodeficiency or cleft palate, children who do not improve in 48 hours of observation. Here again, the antibiotic of choice is amoxicillin, which is the first line drug, and amoxicillin along with clavulanic acid can be used, which is a second line drug for patients with recurrent or persistent acute otitis media, those taking prophylactic amoxicillin, those who have used antibiotics within previous month, and those with concurrent purulent conjunctivitis. Rest all the regimes like azithromycin 1 dose, 3 dose, 5 dose, these are all to be considered for the patient who are having penicillin allergy. And of course, the other antibiotics like cefodoxime, cefuroxime, clarithromycin, clindamycin has to be used cautiously in patients who are having penicillin allergy only. In community acquired pneumonia, war of viral versus bacterial is still there. In neonates, gram-negative enteric bacteria is most common cause in 2 months to 5 years of age. Although Western data suggests viral, but in Indian data, Streptococcus pneumoniae and H. influenzae has predominance, and more than 5 years, Streptococcus pneumoniae is common. Atypical organisms like Mycoplasma and Chlamydia in preschool age and adolescent children is common. In hospitalized children, almost 10 to 14% cases have 2 or more agents. Various studies have shown that the most common organisms for pneumonia are H. influenzae, Streptococcus pneumoniae, Chlamydia, Mycoplasma, and viruses. For the treatment of pneumonia in less than 3 months old babies, they should be best hospitalized and should be given third generation cephalosporins along with aminoglycosides. The point over here to highlight is that while discharging such children, the duration of antibiotics to be completed with the help of oral cephalosporins like cefodoxime and cefuroxime. Otherwise, these agents should be reserved for such scenarios only. In 3 months to 5 years of age, drug of choice is still amoxicillin, and for the injectable also MP, amoxiclav. These are the combination, and third generation cephalosporins can be considered when there is suspected staphylococci. And when there is non-responding staphylococci, we can consider the another agents like vancomycin, teicoplanin, but they are rare situations, and they don't stand for the empirical use also. For more than 5 years of age, still amoxicillin is a drug of choice. The point over here is that we can use macrolides in addition in such age group where the atypical organisms are common in preschool and school-going children. Amoxicillin is the first line therapy. Beta-lactam is producing organism when it is suspected like H. influenzae, Moraxilla. We can use co-amoxiclav in the smaller doses like 30 to 40 mg per kg per day routinely. And in drug-resistant pneumococci, we can add plain amoxicillin 30 to 40 mg per kg per day. Additionally, along with amoxiclav, to make the dose of amoxicillin up to 80 to 90 mg per kg, rather than increasing the doses of clavulanic acid and increasing the toxicity. Some facts regarding LRTI: macrolides can be used in empiric treatment in community acquired pneumonia. Atypical pathogen is unlikely in children 2 months to 5 years of age, so the recommended treatment in this age group is still amoxicillin only. Second generation cephalosporins, azithromycin is recommended in those who are allergic to penicillins only. We should discourage the use of all these medicines in routine empiric practice. LRTI more than 5 years of age, where Mycoplasma pneumonia and Chlamydia are common, macrolides are recommended. Of course, monotherapy with azithromycin, clarithromycin is not recommended unless it is a case of cystic fibrosis where we need to give it for the longer period. How delayed we can start antibiotics? Definitely we can wait till 3 days to start. This is our own academic pulse presented by Dr. Smriti Gupta from AIIMS Bilaspur, where she has clearly shown that delayed antibiotic prescription while following the patient on after 48 hours can definitely decrease the unwarranted use of antibiotics in respiratory infections. Regarding sensitivity of pathogens, Streptococcus pneumoniae and H. influenzae are sensitive to penicillins, cephalosporins, and macrolides. First generation cephalosporins and cefaclor are not effective against H. influenzae. Cefixime does not cover Streptococcus pneumoniae. Resistant to pneumococci is a big concern, and it occurs because of changes in the cell wall protein synthesis. Here, in this scenario, high levels of beta-lactams can overcome this resistance, that is increasing the dose of amoxicillin, rather than addition of clavulanic acid, because it is not the mechanism to increase the sensitivity of pattern in such organisms. In India, pneumococci has low but increasing resistance to penicillins. The CLSI new guidelines show the new susceptibility threshold is 2, unlike 0.06 for non-meningococcal acids. What is the meaning of this? This means that most of the pneumococci are still sensitive to penicillin group of antibiotics like amoxicillin, and we can continue the use of such antibiotics because the literature clearly says that there is sensitivity pattern is still with us. Rather than believing in the literature which is non-authorized or from the representatives, we should believe in such literature. There is high resistance to cotrimoxazole, and 10 to 15% of Streptococcus pneumoniae are macrolide resistant, which is because of genetic mutation, and this problem is worldwide. Regarding H. influenzae, 20 to 50% resistant to many antibiotics, including Amox plus Amoxiclav and macrolides, but not to the third generation cephalosporins, and they should be reserved for such scenario. These third generation cephalosporins like cefuroxime, cefuroxime, and in such scenario, H. influenza vaccination history is very important and useful also. Drug-resistant Streptococcus pneumoniae, DRSP, risk factors for such scenario is recent use of beta-lactam antibiotics usually within 3 months, extremes of ages less than 2 years and more than 65 years, and daycare center attendance. When we are sitting in our day-to-day OPD, we can see so many prescriptions are being written, and we are talking about the recent use of beta-lactams because the OPDs are flooded with antibiotics prescription left, right. In nutshell, amoxicillin is the best empiric respiratory infection antibiotic. Higher doses up to 80 to 90 mg per kg are used in resistant pneumococci. Amoxiclav can be used in beta-lactamase producing organisms like H. influenzae and Catarrhalis, Moraxella catarrhalis. Macrolide resistance is increasing, and it's a big concern. Macrolide use should be restricted only in patients with significant penicillin allergy. The take-home message is best policy is to define your provisional diagnosis first, whether it is viral or bacterial. Delayed antibiotic prescription policy with follow-up after 48 hours is the best approach. Amoxicillin is still the best choice in respiratory infections. Amoxiclav in case of beta-lactamase producing organisms, and macrolide use should be reserved for penicillin allergy patients only, along with these third generation cephalosporins or oral cephalosporins. Third generation oral cephalosporins to be reserved for completion of duration of IV antibiotics following your indoor course or IV course. Thanks a lot. I'm thankful to Dr. Ramakant Patil sir, Dr. Amol Pawar sir, and all EB members, and of course our guide Dr. Subramaniam sir for giving the opportunity. Thanks a lot.
Thank you. It was a very nice deliberation. Just a couple of things that I would like to add is, I think just like we carry our stethoscopes, and otoscope should also be a part of our routine OPDs, because without that, making a diagnosis of ASOM or anything related to the eardrum is very difficult. Secondly, I'd just like to add one more thing to your list of probable scenarios that you said where antibiotics are to be started. You have very nicely given the description. Just one thing is missed out. If there is any sleep disorders in the list, this is on priority that you have to start antibiotics. Here you will not wait for 48 hours. So this is one thing that I would like to add. Like any sleep apneas, anything related to sleep disorders will be in that list of things where you start antibiotics. I think with this, I will let Dr. Subramaniam add to this. Over to you, Subbu.
Yeah, Shilpa, that was wonderful from Yogesh. I don't know how nicely everybody from all over they are having such wonderful presentations. It was not easy to compile antibiotics in respiratory tract infections in 8 to 10 minutes. And Yogesh, you have done wonderful job. Only thing is that there are many people who would wish that there are a couple of comments from me. So therefore, I'll make a comment, not to overrule whatever you have said. Everything that you have said is fantastic and more or less transparent. I had a problem that how to remember when to give antibiotics. See, as long as you are in children, most of the times you don't need antibiotics as much as you would need in adults. This is the first point. Younger, they are less likely that you should prescribe an antibiotic. As you remember, streptococcus infections of upper respiratory are more common in older children than younger ones, defined by the age. And if you're on the highway, you don't need antibiotics. National highway, It starts from the nose, nasopharynx, throat, then trachea, then bronchi, bronchioles. You don't need antibiotic. This is the highway. And I will name the diseases: bronchiolitis, bronchitis, laryngitis, tracheitis, then nasopharyngitis and common cold. They don't require antibiotics. If you go to sideways, you need antibiotics. For example, otitis media, sinusitis, or crypts of the tonsils, which we call it as infection in the crypts of the tonsils is called as tonsillitis. It is sideway. Tonsillar surface is in the main way, but crypts are inside. So that, and alveoli is the dead point, dead end, and therefore that becomes as good as sideway. So what is the difference between main way and sideway? In the sideways, there is stasis of the secretions and infection. And in the main roads, there is hardly any room for bacterial seeding. Bacteria don't seed, they travel. See, you inhale an aerosol bacterium, it goes and settles in the sideways or at the dead end. Are you getting my point? Even though there is a lot of filtering that happens, there is an intact cilia, mucociliary epithelium, mucus, as well as upbeating of cilia that won't allow the bacteria to settle unless the bacteria is pathogenic and overcome the defenses like H. influenza and epiglottitis, for example. Or you can take some other infections which I'm not going to name. But if you want to have the real indications, they are always because of stasis and infection, which is rule in sinusitis, which is the rule in otitis media also. The middle ear works like a sinus only. The difference between the middle ear and the sinus is, except that the ostia directly drains into the nose. The middle ear drains through a hollow muscular eustachian tube. Is that clear? Because there is a hollow muscular eustachian tube separating the middle ear and the throat, there are pressure mechanics that works. If it was only bony drainage, a small ostia from the middle ear to the throat, the pressure mechanics would not have worked. That's why, excessive crying, catarrh, the pressure, retraction of the drum, so on and so forth, all these things happen. And the severe pain, otalgia, all these things happen. So all that you have to remember is that if there is too much of a cry in the child, not in the first day is because of prodrome, but it subsequently also, if the child continues to be irritable and crying, it is otitis media, and you are missed if you have not done the otoscopy. That's most important. The most common way of missing a diagnosis is not examining. And throat examination also, if it is properly done, you will rationalize the antibiotics. Often we tell the mother and the child, oh, and put a torch, nothing will happen except pump and show, and you have to just put a torch into the mouth. This is a common practice done by many pediatricians, and that's wrong. And the tongue depressor, if you take, it has to depress the tongue. You cannot, the common mistake done most often is you take and then do the throat examination. That means you try to sweep the tongue depressor through and through, and lastly reach the last part of the tongue and produce a gag, and so that the child widely opens the mouth, and then you take a photograph and come out. This is a dream, and it should stop. You should never poke beyond one half, anterior half of the tongue, which is not innervated by glossopharyngeal or vagus and does not produce a gag reflex. And you need not have to protrude the tongue and then depress. This is a wrong practice. You have to just open the mouth and keep the tongue inside. This is correct. I'm sorry for being so simple, but it makes a huge difference. This is correct. And you should press the tongue in such a way, it is depression, not entering into the tongue. And a depression produces a nice dimple. Do you have a dimple, Yogesh? No. Smile, no. Let me see if you have a dimple. Okay, you have a dimple. So it should produce a dimple in the tongue, so much so that the throat, the lower part of the tonsil is visible when you depress the tongue. Otherwise, it is an incomplete examination. And if you see the tonsils properly, then you will decide whether it is streptococcal or not, and you are able to prescribe an antibiotic. But otherwise, you will come out with an incomplete findings or incomplete conclusions that will tempt you to give antibiotics, because you have to somehow cover up for your incomplete examination. Let me prescribe. I don't know, there could be something which I'm not able to see, etc. Never repeat throat examination. This should be the last part of examination. Ear examination is thought to be difficult till you do the first year examination. When I was MBBS student, I never saw any ear. And when I became intern, I never saw. When I was PG, I hardly saw here and there. Remember, it all starts later half of your practice. That's when your busy practice becomes less busy. Then you start seeing the ears. When you're very busy, you don't have time to see the ears. Please start seeing the ears. You have to pull backwards and lower. Backwards and lower, and just put the otoscope. You will start seeing the ear. There are a couple of videos that I have done for how to do ear examination and throat examination, which will be released shortly from IAP respiratory chapter. We are releasing a new module called upper airway examination for all the pediatricians in the country. So, you know, this is the most common thing, but not being specifically being what you call SOPs being made, that this is how we'll examine the throat, this is how we'll examine the nose, this is how we'll examine the ears. Examination of nose is often forgotten. Only thing that I want is you should raise the tip of the nose and examine. If there are crusts and if it looks staphylococcal, please remember that the infection can be complicated and pneumonia following rhinitis can be complicated. Lastly, if you find a staphylococcal situation, you will treat, all of us will treat, but lastly, you remember to apply mupirocin intranasally for 5 or 6 days to eliminate community MRSA. So it's very, very important that you eradicate the staphylococcus apart from treating it. Now, lastly, why amoxicillin? How amoxicillin? How much of amoxicillin? Amoxicillin is the best penicillin. Amoxicillin is the tastiest penicillin. If you add clavulanic acid to amoxicillin, you are making it bitter taste. You are first spoiling the taste. Second is you are spoiling the spectrum. And there is a ratio of clavulanic acid to amoxicillin which is important. Higher amoxicillin to lesser clavulanic acid is required in skin and soft tissue infections, whereas required in pneumonias, and lesser amoxicillin to more clavulanic acid may be okay for soft tissue infections and skin infections. What I meant was, if you need more of a beta-lactamase situation, then you have to rise up the dose of clavulanic acid. If you have less of beta-lactamase situation, you have to raise the dose of amoxicillin, because amoxiclav, all of you see your next time when the representatives come, or next time when the mother brings the syrups, please watch the ratio of amoxicillin to clavulanic acid. Is very, very important. Higher amoxicillin is required when you want to really kill. Now, amoxicillin is the only drug which, higher the dose, better is the cell wall breakage. That means less number of soldiers, you can't break the wall. More the strength of the amoxicillin, you can break the cell wall. In urinary tract infection, on the other hand, unlike respiratory tract infection, amoxicillin is concentrated in the bladder, urine, 5 times than the serum. Whereas in the middle ear, it is less than 1/10 of the serum. So therefore, you need 90 milligram per kg in the middle ear. You need 45 milligram per kg in the throat. You may need 40 to 90 milligram per kg in the pneumonias. Non-severe, you can stay with 40-45. Severe pneumonias, you may have to go to 90 milligram per kilo, because you would have no point of no return. You can't step up after 48 hours. You have to really revise your entire spectrum of treatment for pneumonia. So these are some of the tips. The only bacteria to watch for in lower respiratory tract infection is Staphylococcus. If you think that your treatment is misbehaving, then either your diagnosis is wrong, often it is viral, or it is staphylococcal. Otherwise, most of the community acquired bacteria will listen to your antibiotics. You don't have to worry. You won't remember any of the antibiotics except amoxicillin. Azithromycin will not create wonders when amoxicillin does not work, except when it presents as a syndrome of atypical, and there's nothing like a single atypical pneumonia. Atypical pneumonia means which is not typical cell wall, producing bacteria, gram-positive bacteria, or your H influenza. Remember this. So it is apart from the routinely present community organisms, and therefore there is a Legionella, there are very strange names which you can't remember. Each one of them has a clinical feature. Somebody was asking me, can you tell me features of atypical pneumonias? It will become for each organism, there is a different type of clinical features. Did you understand? So in general, what is not typical is atypical, and there's nothing like clinical features of an atypical pneumonia, which I can present to you. Therefore, when you find that the presentation is not typical of a bacterial infection, and when it is not viral, think of atypical. These are my tips, because macrolides have to be used judiciously. It is one of the anti-tubercular antibiotic, azithromycin, and we have to safeguard. These are my tips as far as antibiotics is concerned. Hope that you will prescribe an antibiotic after you write down the diagnosis. Then everything else will fall in place. Thank you very much.
Thank you, Subbu, for those lovely tips. The best tip of today from you, which I learned, was the dose of amoxicillin for the ear, the respiratory tract infection, and the GIT. That was wonderful. I mean, there is a lot of misconception regarding the dosage of amoxicillin. So I think you've cleared a lot of our doubts. Thank you so much for that. And I think we'll go on to our next speaker. The next speaker is from Dhule, Dr. Siddharth Patil. He's consultant at Siddharth Children's Hospital and Vardhan Children's Hospital. And this young man, if I may say, is going to talk on available nebules. So over to you, Dr. Siddharth.
Good evening, everyone. Myself, Dr. Siddharth. I am going to tell about drug use for nebulization for cold and cough, which are bronchodilators, anticholinergics, steroids, mucolytic agents, and antimicrobials.
Nebulizer. Be loud.
Okay. Nebulizer. There are two types of nebulizers: jet nebulizer and ultrasonic nebulizer. Now we will see one by one. In selective beta agonist salbutamol for nebulizer dose is in less than 4 years, 1.25 mg to 2.5 mg every 6 hourly. In 4 to 11 years, 2.5 to 5 mg up to 4 times a day. In more than 12 years, 2.5 mg, which can be increased up to 5 mg and given maximum 4 times a day. For very severe exacerbations, 0.5 mg per kg per hour. The indication is in asthma, bronchiolitis, bronchitis, pneumonitis, hyperkalemia. Adverse effects are irritability, tremors, tachycardia, nervousness, dizziness, hypokalemia, bronchospasm. Salbutamol is available as a solution, 1 ml solution which contains 5 mg. Respules 2.5 mg per 2.5 ml. And Salsol solution which contains 2.5 mg per 3 ml. Budisol respules in combination salbutamol 2.5 mg and budesonide 5 mg in 2.5 ml. Levosalbutamol. For nebulizer in less than 5 years, 0.31 to 1.25 mg every 4 to 6 hours. In 5 to 12 years, 0.31 mg every 8 hours, maximum 0.63 mg every 8 hours. In more than 12 years, 0.63 to 1.25 mg every 8 hours. In emergency, it may be nebulized in combination with ipratropium. Dose is adjusted on the basis of ipratropium content. Available as respules 0.31, 0.63 and 1.25 mg. Tuvulin respules provide levosalbutamol 1.25 mg and ipratropium bromide 500 microgram per 2.5 ml. Adverse effects are same as salbutamol, which are tremors, nervousness, hypertension, vomiting, insomnia. Now anticholinergics, ipratropium bromide. Nebulizer dose is 1.125 microgram for less than 1 year, 250 microgram for 1 to 2 years, 500 microgram for more than 12 years. Dilute in 3 to 4 ml normal saline and given over 10 minutes. It can be used in combination with salbutamol. Adverse effects are dryness in mouth, constipation, bronchospasm. Indicated in chronic reversible airway obstruction and asthma. Available as Respules 2.5 ml, which contain 500 microgram. Now, adrenaline dose in bronchiolitis is in 20 kg 0.25 ml, 20 to 40 kg 0.5 ml, in more than 40 kg 0.75 ml, which can be diluted in 2 ml of normal saline. In anaphylaxis and croup, dose is 0.1 ml per kg, maximum 5 ml of 1:10,000 solution. Indicated in anaphylaxis, acute asthma attack, and croup. Adverse effect are headache, palpitation, arrhythmia, hypertension, subarachnoid hemorrhage. Available as injection adrenaline 1 mg per ml, ampule which contain 1:1000 solution. Now steroids, budesonide for nebulizer dose is 0.5 mg OD or divided into 2 doses, maximum 1 mg per day. In croup, dose is 2 mg in 2.5 ml of normal saline, single dose. If there is poor response, it may be repeated 12 hours or after 48 hours. Indicated in bronchial asthma, bronchopulmonary dysplasia, croup, allergic rhinitis. Adverse effect are oral candidiasis, epistaxis, pharyngitis, nasal irritation. Budesonide is completely indicated, inactivated during first pass metabolism and have minimal systemic side effect. Available as Respules 0.5 mg and 1 mg in 2 ml ampules. Budesol Respules contains salbutamol 2.5 mg plus budesonide 5 mg in 2.5 ml. Now, mucolytic acetylcysteine for nebulizer in infant, 1 to 2 ml of 20% solution or 2 to 4 ml of 10% solution, which can be given 3 times or 4 times a day. Child, 3 to 5 ml of 20% solution or 6 to 10 ml of 10% solution, TDS or QID. In adolescents, 5 to 10 ml of 10% solution 3 or 4 times a day. Indicated in bronchitis, pneumonitis, emphysema, cystic fibrosis. Adverse effects are bronchospasms, stomatitis, drowsiness, rhinorrhea, nausea, vomiting, hemoptysis. Use with caution in asthma. Available as acetylcysteine 10%, which contain 100 mg per ml and 20% 200 mg per ml, 4 ml vial. Now hyperneb, indicated in bronchitis. It increases osmolarity of mucus in the respiratory tract. By its osmotic action, it becomes easy to cough out the accumulated mucus in respiratory tract. Adverse effects are bronchospasm. Available as Respules, which contain 4 ml of 3% sodium chloride. Ambroxol, indicated in bronchitis, emphysema. Nebulizer dose in less than 5 years is 7.5 mg BD. In more than 5 years, 15 mg BD. Adverse effects are nausea, vomiting, diarrhea, allergic reactions. Available as Respules 2 ml, which contain 15 mg of Ambroxol. Dornis alpha for nebulizer 2.5 mg twice or single time a day. Indicated in cystic fibrosis to improve pulmonary function. No mechanism of action, it is recombinant human deoxyribonuclease, which cleaves down extracellular long chain DNA in the sputum, thus reduces mucus viscosity, prevents airway infection and damage to lung parenchyma. Also, it diminishes expression frequency in children in 6 years or older. Adverse effects are dryness, voice alteration, pharyngitis, rhinitis, chest pain, urticaria. Available as solution. .5 mg per 2.5 ml. Antimicrobials, aminoglycosides, tobramycin for nebulizer in bronchitis in more than 6 months and less than 6 years. 80 mg BD for 28 days. More than 6 years, 300 mg BD. In cystic fibrosis, more than 6 months and less than 2 years, 150 mg BD. More than 2 years, 300 mg BD. Amikacin for nebulizer in 6 to up to 12 years, 250 mg BD. More than 12 years, 500 mg BD. Gentamicin for nebulizer, 80 mg twice a day. Indicated in Pseudomonas aeruginosa, MDR TB, XDR TB, pan drug resistant and methicillin resistant Staph aureus. Adverse effect are nephrotoxicity, ototoxicity, cough, bronchospasm. Miscellaneous antibiotics, azithromycin for nebulizer 75 mg TDS, indicated in Pseudomonas. Adverse effect are diarrhea, vomiting. Meropenem for nebulizer in 6 to 12 years, 120 mg twice a day, 125 mg twice a day, more than 12 years, 250 mg twice a day. Indicated in beta-lactamase producing microorganism. Colistin for nebulizer in less than 8 years, 1:10 lakh units BD. In more than 2 years, in more than 8 years, 2 lakhs units BD. Indicated in Pseudomonas. Adverse effect are nephrotoxicity and neurotoxicity. Antifungal and amphotericin in less than 10 years, 5 mg BD. In more than 10 years, 10 mg BD. Indicated in chronic aspergillus infection. Thank you.
That was a very nice presentation. I don't think I would have ventured into a dosage kind of a talk. It was really very nice. I think you've put a lot of hard work. I think I'll let Dr. Subbu speak on this. Completely over to you, Dr. Subbu.
Siddharth, this was wonderful presentation. The presentation of Nebule was in a nice capsule for all the people to watch. You know, you have really given a nice nebule for everybody. And nebula means, you know, a big nebula in solar system is different, but nebule is a small one. It's basically popularly also called as respule, and there are many experiments done with the respules. They should have, most of them have got fixed drugs dosages. Most of them have fixed volumes. Most of them are ready to use, and they are usually non-irritant, and you have dosages available for younger and older. You don't have to bother and remember too much of milligrams, which Siddhartha has nicely presented. That is scientifically acceptable for most of us in practice. It's okay, because otherwise, until put otherwise, most of the nebulizing solutions available in the residual forms are in the moderate limits of the dosages for salbutamol, levosalbutamol, budesonide, your ipratropium, and your acetylcysteine, so on and so forth. So you need not have to remember that milligram dosages that are available. Now, as far as the nebulizers are concerned, we are going to have the next talk. So therefore, let me restrict myself to nebules that are available. Very commonly, one of the most confusing thing for the pediatrician, which I will put it now across, the question number 1, which is burning for most of the pediatricians: should I use salbutamol? Should I use levosalbutamol? Should I use budesonide? Do you all agree on this one? This is the area which everybody requires clarification. Is it okay if I just add budesonide to each and everything in respiratory practice? You know, somehow it will take care, some of the symptoms will come down, and it is not having side effects. This is not a correct approach. It may not work well. So therefore, my dear friends, use salbutamol or levosalbutamol. Levosalbutamol is expensive salbutamol. Only advantage of levosalbutamol over salbutamol is half the dosage, double the price, and less tachycardia. That's all. And tachycardia will settle with bronchodilation. And therefore, you don't have to worry whether you use salbutamol or levosalbutamol, because as and when the hypoxia improves, the tachycardia comes down. So the marginal side effect of or advantage of levosalbutamol over salbutamol is more theoretical than in clinical practice. That is point number 1. Point number 2 is, should I use the popularly available Duolin instead of Levolin? You know, this is again a common question, and the answer to it is very simple. The Duolin was initially described and prescribed for adult with COPDs, where you need both broncho beta 2 agonist as well as anticholinergic action. Did you understand? So it was originally designed for an adult, but extrapolated for usage in children. Remember, the ipratropium is good anticholinergic. Independently, ipratropium doesn't work well. Ipratropium works well on solbutamized airways. So therefore, it's always an add-on drug, not an independent drug. Now, ipratropium can be given 6th hourly or 4th hourly, while salbutamol can be given even back to back, while you don't need ipratropium back to back. Am I clear? And therefore, the combination doesn't serve the purpose. If you're using a combination, it means you can use duolin every 4th or 6th hourly, and in between you need Livolin or salbutamol. That is Astalin or whatever, that any other companies that you would use. Am I clear on these two concepts? This is very, very important for you to understand. And therefore, you have understood what is the difference. Now, the next common question which I always get from the practitioners is, the nebule is 2.5 ml, but the nebulizing chamber should contain 4 ml. What should I do to make up another 1.5 ml? This is a common question. You can add the second respule, or you can add normal saline. Both are fine. You can add the second respule if it is bronchodilator, because that much dosage is enough. Now, regarding and lastly, extended use of nebules in the form of mucolytics, they are reserved for the diseases which produce lot of mucin, like cystic fibrosis, bronchiectasis, etc. And special situations like, colonized airways where we want to have microbial clearance, like aminoglycosides as nebules being used. You remember that aminoglycosides are the best eye drops that are available, quinolines and aminoglycoside. Have you not prescribed gentamicin eye and ear drops very commonly? I mean, eye drops, okay, so commonly. The gentamicin is a very good topical, aminoglycosic acid is a very good topical antibiotic. And topically, it can be used as a nebule in some of the situations where you need not have to push so much of systemic antibiotics, like all the diseases where the mucociliary epithelium is damaged and there is unusual colonization, especially Klebsiellas. So that's when the aminoglycosides and quinolines makes huge difference in respiratory practice, and that's where even the pseudomonal colonization and Klebsiella. That is when these aminoglycosides are very, very useful, and more so for even pseudomonals as well. So that's when you use the antibiotics. Rest of my comments on the nebules I will reserve it for the next talk, and I will not cover up what the next speaker is going to speak. If you have doubt on the dosages, they are available in the leaflets. Most of them, they are safe to use. The nebulizing particles that are going to come out of a nebulizer, they are very, very important, and the area to be driven is very, very important. If you're using adrenaline, your target in croup is upper airways. If you're using adrenaline for bronchiolitis, then your target is lower airways. So therefore, dosages are different for upper airways and lower airways. Now, you use more and higher concentrations of adrenaline when you are targeting upper airways, because you need alpha effect of adrenaline. It has alpha and beta effect. Alpha is decongesting effect, and beta is bronchodilating effect. So that's when therefore you would use lower doses of adrenaline for bronchiolitis and higher doses of adrenaline for croup. I'll just tell you the dosage: 5 ampules of adrenaline roughly for croup, and single ampule diluted for lower airways, especially bronchiolitis. This is a simple oversimplified version for the practicing pediatricians. Rest of my comments I'll reserve for the talks on the nebulizers when I have to again coming back on nebulization concepts. Back to you.
I will invite Dr. Neha to take over now and introduce the next two speakers. Over to you, Neha.
Thank you, Shilpa ma'am. Our next speaker is Dr. Amol Deshmukh, practicing pediatrician at Sri Siddhi Vinayak Hospital, Hingoli. His topic is nebulizer types, maintenance, and good practices. Now, over to you, Amol. Start sharing your slides.
Good evening, everyone. Myself, Dr. Amol. I am representing Hingoli IAP here. In this presentation, I will discuss about nebulizer types, their maintenance, and good practices about nebulizers. So, as we know, nebulization is a process of medication administration by inhalation. So it utilizes the device called nebulizer, which transport the medication to the lungs by means of inhalation. And this nebulization, which is used to liquefy and remove the retained secretions from the respiratory tract. So these are three main types of nebulizer. One is jet nebulizer, which is most commonly used nebulizer in our office practices. Other one is ultrasonic wave nebulizer, and third one is mesh nebulizer. These are different types of nebulizer available in the markets. So most commonly used, which is a jet nebulizer. The principle of action of jet nebulizer is it uses the compressed gas to make the aerosols, which are the teeny particles of medication in the air. So this compressed gas is forced through the tubing system, which is connected to the nozzle where our liquid solution is kept, so that this liquid solution get converted into the aerosols. The advantages of this jet nebulizer, which is portable, small particle size can be delivered, which is less expensive, and not much breathing coordination is required in jet nebulizers. So this is a jet nebulizer, which is most commonly used in our OPD. This is a pictorial diagram showing the mechanism of action of jet nebulizer. As we can see, the compressed gas which converts the liquid solution, the reservoir of solution which is kept in the reservoir into the droplet to reach the patient side. The second one is ultrasonic nebulizer. This makes an aerosols through the high frequency vibrations, and the particles are a bit larger than jet nebulizer. And ultrasonic nebulizer works on the effect of piezoelectric effect. This ultrasonic nebulizer is a bit expensive, and it heats up during the operation and less treatment time. This one is ultrasonic wave nebulizer. And this is the pictorial diagram showing the principle of action. As you can see, there is a piezoelectric transducer from where the ultra high vibration delivered, and the liquid solution get converted into the aerosol so as to deliver the patient in the form of vapors. The third one is mesh nebulizer, in which the liquid passes through very fine mesh to form the aerosols. The mesh nebulizers are in which also a very small particle size delivered as compared to the ultrasonic wave nebulizer, but this is a bit expensive, and the mesh used in the mesh nebulizer, which is very delicate. But these mesh nebulizers are quite and more portable than other nebulizers. This one is a mesh nebulizer, and this one is a pictorial diagram. As we can see, there is one vibrating mesh over the liquid medicine cape, and this mesh contains some piezoelectric crystals from where this liquid medicine gets converted into the vapors forms. So the equipments we required for the nebulizer process, the nebulizer device, nebulizer connecting tube, then mouthpiece and mask according to the age of the patient, then medication card with the patient, and normal saline for dilution. Then procedure of nebulization, the comfortable position to the patient. Then we should assess the vital signs of the patient. We should teach the proper way of inhalation, then preparation of all equipments, then placement of medication into the medication chamber, proper tubing connections of the nebulizers, then offering nebulization to the patients. This process, the nebulization process usually takes 5 to 10 minutes is adequate for the nebulization. We should never continue till the liquid dries up in the cup. We can stop when the spurting sound is there. So this is a pictorial diagram showing some key aspects of nebulization. So the fill volume is really 2 to 5 ml. The nebulization time generally between 5 to 10 minutes, and the most important is nebulization end point. So nebulization for about a minute after spurting sound occurs, we can stop the nebulization, and steady normal breathing interspersed with occasional deep breaths is optimal for nebulization. The optimal flow rate which is required for the nebulization is 6 to 12 liter per minute. At this rate, the 30 to 50% are in the respirable range of 2 to 5 microns to reach the almost last 6th generation of alveoli. and 2 to 3 ml of medication usually sufficient for the dilution. And in case of small children, the face mask can be used. We should encourage them into the breathe from the mouth, not through the nose, so as to the medication reach to the proper site for the proper desired action. And in case of older children, mouthpiece to be used, as there are ear leak chances are very less with the mouthpiece. The most important is the maintenance of nebulizer machines. After each treatment, we should rinse the nebulizer cup thoroughly with warm water. We should shake off the excess water and let it air dry. And at the end of each day, we should wash the cup, mask, and the mouthpiece in warm water with a mild detergent. And we should rinse it thoroughly and let it air dry. We don't need to clean the compressor tubing. Every third day after washing equipments, disinfect it with either vinegar, water solution, or disinfectant solution provided by the manufacturer. Soak the equipment for 20 minutes and rinse it well under a steady stream of water. Shake off the excess water and let it air dry on a dry paper towel. When it's totally dry, store it in zippered plastic bag. This one is a pictorial diagram showing the maintenance of nebulizer. As we discussed, we should disinfect daily. In step 1, we should clean the container, so all the accessories except the tubings, which need not to be disinfection for 30 minutes. The disinfectant can be used commercially available medical disinfectant or mild detergent, or the vinegar solution, which can be prepared by 1 part of white vinegar and by mixing them with 3 parts of warm water. And the steps 2, which contains with the clean hands, rinse all the accessories with warm water and let it air dry. And in case of maintenance, do not open the accessories cabinet. All disassembly and maintenance must be done by the manufacturer manuals. The filter should be changed when it discolors totally. Do not reuse or wash the filter or substitute it with any other material. And compressor, we should wipe outside the compressor with the clean cloth regularly. Then last part 1 is the good practice of about the nebulization. As there is a nebulization hesitation by many parents due to the thought in the parents' mind that it get addicted to the patient, or they may cause stunting in the patient. So we should counsel them. These are very safe process of medication, and there are very less side effect of nebulization process. And we can stop nebulization once the symptoms are better. And in case of minor cough and cold, there are many parents who are giving over medication and medication nebulization at home. So we should counsel them the need of when there is an actual need of nebulization. And with nebulization procedure, we should tell them about the hygienic practices and the proper disinfection and maintenance of nebulization at the home. We should teach them about the proper dilution, not only medication to be kept in a chamber. We should nebulize with 2 to 3 ml of normal saline, the proper position of the child, as many infantile age group came with the crying, and in case of crying, there will be more exhalation than the inhalation. So we should ask them to give nebulization when the child is calm, and they should always check the medication card provided by the their physician, and about the storage of the nebulizers. Thank you.
That was a wonderful presentation by Dr. Amol. I agree, nebulization, proper technique, maintenance, and use of spacer and mask for smaller kids. These hesitancy is faced by many parents. And if understood once, then it's a win-win situation for most of our patients. Now I invite Subbu sir to please enlighten us more on this.
There are 1 or 2 lines, because for want of time, let me be very brief. The nebulizer which makes most noise in the practice is a jet nebulizer, and it is the cheapest available, and that produces larger particles. That's very, very important. And the particles that come out of a jet or a fountain, you know, the droplets, they are dissimilar in size. You may have larger, smaller, etc. If you take the peripheral smear of the nebulizing particles that come out, they are there is basically anisopoikilocytosis from a jet nebulizer. From an ultrasonic nebulizer, you may get normocytic, normochromic kind of particles that are coming out. From the mesh nebulizer, you can get uniformly spread microcytic particles that are very small and they will reach to the distal airways. This is very, very important. A jet will produce dissimilar particles. And therefore, jet nebulizers are very useful when your target is proximal airways, because larger particles get deposited in the proximal airways. Let's say you are for a croup, you are for an acute bronchitis, plus or minus asthma, which is medium airways, where you use in moderately severe asthmas, not at home management or not very fast. You can use MDI with spacer. Am I clear on this? So therefore, in these situations, you can use a jet nebulizer. Ultrasonic nebulizer is very useful when you know that a particular candidate has to use it for longer periods of time, and in ICUs or in places where sound is not, should not produce the disturbances, and a particle size has to be better. For example, if you are targeting medium and smaller airways and smallest airways, then you should use an ultrasonic nebulizer. Please remember this. And if you use a mesh nebulizer, it is much, much better. The advantage of a mesh nebulizer is it costs around 8 to 10,000 rupees. They are available. You can give smaller volumes like 0.5 ml. You can nebulize. You can nebulize 0.1 ml. I mean 1 ml. So if you are using drugs like colistin, you can't afford to give 4 ml of colistin. It's very expensive. Then you need a mesh nebulizer. So if you're using antibiotics, then you will use a mesh nebulizer. If you're using general drugs, then you use a jet nebulizer. And if you're targeting distal airways, then you should use an ultrasonic nebulizer. This is as far as the choice of the device is concerned. Now, the second question is, should it be oxygen driven or compressor driven? What you see in the nebulizer, that small where you fill the chamber, that is the real nebulizer. Did you understand? After when you fill the chamber, you put something on top. No, that is the nebulizer really. And what you see, that box is actually an air compressor. And air compressor can be replaced by centrally available oxygen source. When you connect it to centrally driven oxygen source, the flow rate should not be 2 liters per minute, and a nebulizer being connected. This is again a mistake done by most of the staff nurses. The flow rate should be at least 5 to 10 liters per minute when you are nebulizing. So sufficient pressure is generated so that there is a jet nebulization that happens from connecting to an oxygen source. This is the second question. It came as a question, therefore I am answering. Now, if you put 4 ml of the solution, 4 to 5 ml of the solution, and if you use optimum pressure of a compressor or an air oxygen source, then the nebulizing time that is required is 5 to 10 minutes. If you keep 2 ml, then you will finish in 2 minutes. If you keep 10 ml, then you would require 20 minutes to nebulize. That means if you keep larger volumes to finish that chamber, you need longer time, and the child will not be able to breathe with lamellar flow and comfortably for such a long period of time. So therefore, to optimize the time of nebulization, you have to optimize the volume of nebulization and the nebulizing machine that you have to use. So therefore, optimum way to do it, this is very common. The second common mistake that is done in the practice is you will nebulize with normal saline. Put some normal saline, make some noise, and keep somebody every 4th hourly in the hospital. The normal saline doesn't help much because the isotonic fluid of the airways and itself contain normal saline. There is increased nasal discharge, there is increased bronchial discharge, there is a wet cough that is coming out. They all contain saline. You understand, there is nothing that you add extra. Studies have shown that you have to increase the tonicity of the saline and make it hypertonic so that there is some effect that is produced and that is useful. Please remember, discourage the normal saline practice and increase the practice of hypertonic saline. In practice, whatever benefit that it is going to give, it is going to be useful. Home nebulization has to be strongly discouraged. It is not a problem with the nebulizer. It is a problem with the nebulizing mindset. You have to clean the nebulizer and use appropriately. You have the best photographs coming from the mobile. You have the worst photographs coming from a professional cameras. Do you agree? It depends on how you take. And the technique is important. How you educate the mother is important. Any nebulization done in an uncooperative child, crying child is taken as null and void. It is not going to be effective at all. Because children, it is not what you see the gushy aerosols. It is very important how much the child inhales and inhales quietly. That's important in a nebulization. Nebulization is a passively driven aerosol infusion into the airways, not active inhalation. And therefore, a child should be quiet. And by no means it should be sleeping. Because in sleeping, the FRC or the volumes and capacity of the lungs are reduced, airways tend to collapse, upper airway tends to collapse, and nebulization is not good. Mouth driven nebulization is better than nose driven nebulization. These are some of the small points. If there are questions, I will answer them in the chat box. For want of time, I am cutting down the concept on the nebulization. You should know how to clean the nebulizer. Clean only the tubular part of it. You don't have to clean the compressor. People are washing the compressors also. You can just wipe the compressor and wipe the tube, while the chamber you have to open and flush it, and that's how you clean the nebulizer. Please don't try to put the water into the compressor because that is not going to help. You can go ahead, ma, please.
Thank you, Sidhu sir. And our next speaker is Dr. Bharti Kainar, consultant pediatrician from Manipal Hospital, Pune. Over to you, Bharti ma'am. Please unmute.
Thank you for kind introduction. My topic is counseling in OPD in respiratory tract infection. My slides are not moving.
You have to go back then. Neha, can you do from your side? Bharti ma'am, please wait.
Just click once on the slides. It will start.
Counseling in OPD in respiratory tract infection. Let's look at scene 1. Mother enters clinic with 1-year-old Raj. Good morning, doctor. Good morning. My son has fever, cough, cold. Is fever high or low? No. But doctor, are you giving fever medicine? Ciprofloxacin. Is fever better? Yes. No fever since 1 day. Is cough dry or wet? Cough is wet. Doctor, I gave nebulization yesterday. Oh no. Why did you give nebulization? It is not right thing to do. Phone bell rings. Doctor talks to the receptionist. How many appointments are there? Doctor examines the child. Don't worry. This is viral respiratory tract infection. Give medicines I have given to you. Cough will be fine in 5 days. Looks at watch. Calls for the next patient. Did not give enough time to mother. This is an example of bad counseling because doctor has used close questions, the answer to which is either yes or no. Mother did not get enough time to describe symptoms of her child. Doctor has disagreed with her idea of giving nebulization. As a result, lost opportunity to extract maximum information from the mother, use judgmental words, medical words, and given commands. Now let's look at the scene 2. Mother enters clinic with 1-year-old Raj. Good morning, doctor. Good morning. My son has fever, cough, cold. How is fever? High. Lasted for 2 days. Since today, no fever. What have you done for fever? I gave ciprofloxacin. Once fever was above 102 degrees Fahrenheit, I did sponging with water. How is fever now? No fever since 1 day. How is cough? Doctor, cough is wet. Comes whole day. I gave cough syrup and nebulization. Why you gave nebulization? My elder daughter used to get cough, wheezing, and fast breathing till she was 5 years old. I thought Raj also has same illness since I gave nebulization. Phone bell rings. Doctor ignores. Doctor greets the child. Hi Raj. Examines child thoroughly. This looks like viral infection of upper airway. Raj is in recovering phase as no fever. Sometimes cough may take up for up to 2 weeks. No need for nebulization at present. Chest is clear. So reduce cough syrup. You can stop fever medicine. Mother smiling. Okay, doctor, my child is not eating. What food to give? You can give small frequent food like dal, rice, khichdi, porridge. Continue breastfeeding. Explains danger signs, calls for follow-up. This is an example of good counseling because doctor has asked all open questions and mother has a chance to describe symptoms of her child. Doctor agreed with her idea of giving nebulization, which as a result, mother gained trust in doctor and she gave more information. No medical words or judgmental words are used and doctor gave suggestions. Points to be noted before counseling. Viral respiratory tract infection, there will be prominent fever, cough and cold through day and night, history of contact. In bacterial respiratory tract infection, cough with painful swallowing, submandibular lymph nodes will be palpable. High fever with blocked nose, mouth breathing, snoring, suspect adenoid hypertrophy. Thick nasal discharge suggestive of sinusitis. No fever or mild fever with cough more at night, early morning, with wheeze and or breathlessness, with personal or family history of atopy, suggestive of hyperreactive airway disease. Child wheezes with mild fever, cough, cold, suspect wheeze-associated lower respiratory infection. Respiratory tract infection with viral etiology, fever subsides in 3 days, cough may persist for up to 2 weeks. Respiratory tract infection due to bacterial infection, fever may be mild to start with, rises on 3rd day. Localization of infection in acute tonsillitis, pharyngitis in throat, ear in otitis media, and lungs in pneumonia. In bronchiolitis, 6 to 1 year old baby with tachypnea, wheezing, mild fever, wheeze-associated lower respiratory infection, fever, cough, breathlessness in a child whose age is less than 5 years. Pneumonia, fever, breathlessness, sick-looking child with lower chest retractions and grunting will be there. Symptoms which will require good counseling. In case of cold, whether discharge is watery or thick. In case of cough, detailed history of cough as to dry or wet, nocturnal, early morning, trigger-induced or seasonal. Fever, mild fever with cough and cold, usually mostly viral, needs symptomatic treatment. Whether child sick or healthy in between fever, whether cough was associated with breathing, wheezing or breathlessness. Symptoms which cannot be ignored. Respiratory tract infections more than 6 times in a year or more than 3 times in 6 months warrants attention. If child has weight loss or growth faltering, malabsorption and presenting with recurrent respiratory tract infection, needs careful evaluation of history to rule out cystic fibrosis. Cough with extra respiratory symptoms, look for atypical organisms like Mycoplasma, chlamydia. Prolonged cough, which is paroxysmal associated with post-tussive vomiting in unimmunized child, suspect pertussis. Cough which is nocturnal, early morning associated with activity, wheeze and or breathlessness, suspect hyperreactive airway disease. Wet cough lasting for 4 weeks, suspect protracted bacterial bronchitis. Sudden onset cough with history of choking in healthy child, suspect foreign body. Do's and don't during counseling. Maintain head level, remove barriers, pay attention to what parents says, ask open-ended questions which will start with how, why, when, what. Show responses and gestures to show that you are interested. Praise if parents are doing right, accept what parents are saying, give enough time, listen, clear communication with parents and give 1 or 2 suggestions. Do not use close questions which will start with do you, is or are you. Avoid disagreeing using judgmental words or medical words and making commands. Diet is important. Yes, it is the most important question asked by parents in office practice. Because infants with cough, breathlessness or tachypnea may not be able to take feed. Sometimes children may have pain in the throat, they may have difficulty in swallowing. As a result, they take less food. So for the infants less than 6 months, express breast milk can be given. For small children, frequent small feeds, maintain hydration, warm liquid diets, which is soothing, simple, easy to digest food like dal rice, khichdi, protein diet, and after patient recovers from illness, 1 extra meal till 2 weeks. Fruits like papaya and apple could be advised. Don't yield to parental pressure as to start antibiotic for every respiratory tract infection, nebulization for every cough, frequent cough cold syrups, investigations like CBC, CRP, XHS for every fever, cough, and cold. Advise home monitoring regarding in case of fever, maintain fever chart, follow up in case of not improvement in cough, monitor for red flag signs such as fast breathing, poor oral intake, reduced urine output, rash. Due to COVID pandemic, most of the parents have pulse oximeter with them. For a child who is active, playful with mild tachypnea, we can advise them to monitor oxygen saturation with pulse oximeter at home. Contact healthcare personnel immediately if worsening of cough or breathlessness. Home remedies like honey could be advised, but be careful for the children below 1 year of age for the risk of infant botulism. Tulsi ginger decoction, warm liquids, warm water gargles, steam inhalation supervised by parents could be advised. Parental education about the natural history of cough. Majority of cough resolves in 2 weeks. Cough remedies are to relieve and not to cure cough. Complete antibiotic course advised for bacterial respiratory tract infection. Avoid self-medication such as antibiotics, nebulization, cough syrups for prolonged time. Adherence to treatment in cases of asthma and tuberculosis is important to have maximum compliance. Counseling for prevention of respiratory tract infection, treatment of contact like elder sibling or adult. Explain hygiene like wearing mask, cover nose and mouth while coughing, sneezing. Stress on completion of vaccination like flu vaccine before monsoon, H influenza type B vaccine, pneumococcal vaccine, and measles vaccine. In case of an outbreak, avoid traveling in crowded area. So take home message is counseling in respiratory tract infection in OPD is essential skill every pediatrician must know. Beware of symptoms associated with respiratory tract infection which cannot be ignored. Clear communication with parents so as to their understanding of illness and the treatment advice is a must. Accept, give adequate time, listen, praise parents. Don't yield parental pressure to start antibiotics, nebulization, investigations. Explain red flag signs, home monitoring, diet, and timely follow-up. So if we follow appropriate counseling practice in pediatric OPD in respiratory tract infection, we can definitely convert first picture into a second picture, and the pediatrician will get immense joy and satisfaction. Thank you for patiently listening to my presentation. I would like to thank Maha IAP and Maha IAP Women's Committee for giving me opportunity to present on this wonderful platform, and Dr. Subramania sir for guiding me for my presentation.
Thank you, Bharti ma'am. Counseling patients rather than their parents is the toughest part, what most of we pediatricians face in our daily OPD. But this was what a perfect way of explaining the technique by cases and dialogue. Now I invite Subbu sir to please add on.
Yeah, I don't think there is anything to add to Dr. Bharati. It was one of the lucid presentations on counseling. Only just because of the formality, let me tell you a couple of things. You become best counselor over a period of time. In the beginning of practice, as soon as you finish MD and you go there, you explain them half an hour, and the patient just walk out to the next pediatrician. You will not know what to speak. Over a period of time, you will know the content and the variations and the softness through which, as an art, you have to present to a mother in distress, or to the parents for that matter, and particularly to the grandmother who is little reluctant to listen to an younger pediatrician. And these are some of the difficult counseling situations that we get in practice, especially when the child is not doing well after you have prescribed. And if they come back to you for the second visit, that's when I think you please don't rush through the counseling. That's when you need to counsel. Don't go on defending what you have done in the first visit, but please come back to the reality and explain them the illness. Most often they will be understanding the terms and conditions. Lastly, in counseling, remember that whatever you have read in medicine, You have to translate it into local language and make them understand. Do not complicate and push through the words. And that ventilator associated pneumonia, your child has got VAP. You know, they don't understand anything out of that hat. So please remember using all the shortcuts, short forms. And lastly, counsel in front of the CCTV. Because nowadays there is a medical legal problems, and bigger hospitals or most of the hospitals nowadays have a CCTV. If you counsel in front of the CCTV, there is an evidence that you have counseled. Because sometimes if there are any untoward events, it protects you from, works as a defense. Learn from the other scopes of medicine, like Ayurvedic people. You just see homeopathic people, nicely they will counsel. They don't give anything, but we give everything, but we fail to counsel. This is very, very important. You watch in the TV, the way they speak about asthma, he doesn't know anything about asthma, but you see the way he speaks, yeah, wow, and all that. These are very, very important things. There are things to learn from our other fields of medicine as well. And you will be a good counselor provided you go through these counseling arts. Lastly, let me end up by telling you, always doctors should be counseling the parents. If it happens other way around and parents start counseling the doctors, and I think that is the worst day that you can go through. And please avoid a situation like that when the parents start dictating or advising the doctor, can we take an X-ray? Shall we do a Vidal test? Shall we do a throat culture? They should not be, shall we do a CT scan, whole body checkup and all that. Please avoid going to that stage by stage phased way. Please document that you have explained to the mother and put your signature on the prescription slips. It makes huge difference. At least you will know that when they come with the slip next time that you have already counseled partly. These are some of the tips on counseling. Anyway, it will take a long session of ours, and I'm sorry for making it brief for you at the cost of some of the messages. But everything has to end, and hope that this IAP Mahayagna in respiratory was fruitful for you. Many of the speakers have sent the slides to me and took some kind of corrections, but I'll tell you more than what corrections I have done. At the end, they have gone back and did their original presentation. Never ever I will take any claim of any of their presentations. They were original from the speakers, and they are wonderful. And they were all nice Hire, Anmol Hire, and all of them are wonderful future speakers of Maharashtra IAP. Hope that this exercise was useful for young upcoming leader as well as the patiently listening pediatricians across. If you have still confusions, it is going to happen. Please become members of the respiratory chapter apart from being members of Maharashtra IAP, and join us. And also, if you don't want to join, at least WhatsApp to us. We will reply to all your questions patiently. Thank you very much. I have shared my WhatsApp number in the message box. And I will thank Maha-IAP, the young brigade of all my dear juniors, starting from Dr. Shilpa, with whom I worked, Dr. Rajendra, who was my senior in Pune, Dr. Neha, all the speakers of today, and my dear Anmol Amol. Thank you very much for giving us the opportunity. And Ramakant sir, the president with whom I had shared when I was EB member along with him. Thank you very much for giving this opportunity.
Subbu sir, a few queries and comments. These people should not go with the impression that for otitis media, we will be starting 90 milligram per kg of amoxicillin to start with. That is one thing. Secondly,
no, that is not required, not necessarily 90 milligram per kg. It only means that in otitis media, if the fluid is under pressure, then only the MIC may not be achieved. And not all otitis media are like same. Two otitis media are not the same. So therefore, 40 to 50 milligram per kg or 50 to 60 milligram per kg is more than enough in our day-to-day practice. Yeah, you have made a good point, Ramakant. I agree with you.
Secondly, the role of nebulization is very minimal in the practice.
Yeah.
It is the inhalational device with the spacer and this is the standard of care unless until patient who is needing hospitalization in status asthmaticus, and still jury is not out whether we should go with oxygen driven nebulization or not. Uh, this is what I feel you should be a further decipher on that about the nebulization.
So I agree that nebulization as a
One point
practice should be
at all.
strongly discouraged in asthma, but it is inevitable in some of the illnesses apart from asthma.
Also about this night, preferably if we are giving, we should be using jet nebulizers rather than a piezoelectric electrode device, because it is a large molecule, and if we are using the ultrasonic nebulizers, it may get activated. One point is that nobody might be doing that, but never ever dilute it with the distilled water. As you have rightly done, we should be using normal saline, and more than that, you should be using more of 3% normal saline. And sentence from you about 7% would have further enlightened. But I think it is still not that way recommended. 3% should be the enough for bronchiolitis and not the 7% sodium chloride. And are there very low molecular diclomethane available, which will be less than 1 to 2 micro distinct size, which will be reaching the really bronchioles, tertiary bronchioles, which will be helping in a more even distribution and have a good bronchodilation. So is it available? Very small size
Mesh nebulizers are available.
diclomethane.
Mesh are available.
Okay.
But you don't need
Thank
a mesh
you.
nebulizer for office practice.
No. I'm not saying about mesh or smart nebulizer, because smart nebulizers are particularly more useful. I'm saying about the very low molecular beclomethasone, which produce the particle size of 1 to 2 micron. Because if less than 1 micron, it will have Brownian movement. But 1 to 2 micron will maximum reach to the bronchioles, tertiary bronchioles.
Yeah,
Where we
you
will have
raised
better.
you raised a very important point regarding steroids and nebulization. What studies, a larger number of studies have been done with bronchodilators and molecules as the what should I say, the key particles for delivery studies. They have not used so much of steroids for the studies. See, when you take up a study to compare, let's say jet nebulizer, ultrasonic nebulizer, 1 year versus 6 years, they have used bronchodilator as the testing drug. Nobody has tested steroids. Please remember, studies on steroids is very less. Number one. Number two, steroids, there is a suspicion, and you go through the literature, Cochrane, they say that steroids are not well delivered into the airways from the nebulizers. Please remember, they are going to get oropharyngeal deposition and proximal airways where the side effects are more than being delivered to distal airways where really we require them. So it is difficult to deliver a steroid. So therefore we say in acute asthma, we need a systemic steroid, not the nebulized steroids. That's the point. Like the size of the particles is non-uniform from steroids. And steroid, you just see the today, both of you, all of you, please go back and see the respules. Budesonide is a suspension. So levosalbutamol is a solution. There is a difference between solution and suspension. Steroid is a suspension and a very bad liquid as a nebule, whereas salbutamol or levosalbutamol is a solution which is homogeneous and better for dispersion. So we even err at the level of even manufacturing. There are no good solutions of steroids available. They are suspensions of steroid. So therefore they are not good. I will give the example of Astocalcium versus Calcimax for you. The lime settles in Astocalcium syrup, which is a suspension, and in Calcimax, you can mix well or shell cal. So I'm just giving an example for the practitioners to understand. Ramakant, over to you.
One last point is that Again, we should not go in home with the message that ipratropium to be used 4 to 6 hours. Ipratropium bromide, the place is very specific. When we have given salbutamol, still not responding, then only the ipratropium bromide, but it may not be repeated 4 to 6 hours. The role of ipratropium bromide in particularly pediatric asthma is very minimal. So it should not be a combination and not to be given 4 to 6.
Yeah, I think what the speakers have prepared, not for asthma alone, the nebulization, nebules, and all the drugs, they were not following the ATM module. They were seeing all spectrum of diseases where they can be used. Let's say ipratropium is used for a disease like COPD in children. It can happen. So therefore, in such situations, how do you use? It is not necessarily only in asthma that we are talking. So therefore, that messages were given as from the drugs point of view. As far as asthma training module is concerned, we have prepared the module with all the experts in place. So we have to follow the protocol for management of asthma, which is different from discussion on drugs, where drugs can be used in situations other than asthma. I think let us make it very clear. If you're using anticholinergic for the anticholinergic properties, then it's different.
Thank you for your time, and it was a wonderful deciphering on every speak, and many new points were added. Thank you, Subbu. You were every time and as usual so enlightening. Thank you. And
So,
I congratulate all the speakers for preparing wonderful. The slides were so good, so nice. So they should be kept as a treasure. And I request Neha to put the WhatsApp group of the slides for perusal of the people. Thank you.
sure, sir. Now we proceed toward the vote of thanks because all the queries have been already solved. So now, today we had a blockbuster session of Tuesday Take. And first of all, I with wholeheartedly like to thank Dr. Subramaniam sir for accepting our invitation for being expert for today's Tuesday Take program. Sir has guided all the speakers, even being so busy, he has kept track of each of them and their presentations. I may say he is an excellent teacher and prepares his students from tip to toe. Sir, your expertise, comments, and guidance was really very helpful for all of us. Once again, thank you, sir, for being part of MahaIP Tuesday Take. I would like to thank our MahaIP President, Dr. Ramakant Patil, sir, and our Secretary General, Dr. Amol Pawar, sir, for giving us their support and MahaIP platform. Thank you, Gangolia, sir, Renu Goralkar, ma'am, for joining and motivating us, also staying till end of the program. I thank Maharashtra Medical Council and our MMC observer of today, Dr. Rajendra Kulkarni, sir, for joining us from Europe and also granting all the participants one MMC point for today. I thank all the 5 speakers of today, Dr. Soumya, Dr. Yogesh, Siddharth, Amol, and Bharti ma'am for preparing excellent presentations and delivering their topics wonderfully. Congratulations to all 5 of you. Also, thank you to our Women's Committee Chairperson, Dr. Sonali Shurate ma'am, and my co-moderator, Dr. Shilpa ma'am, for moderating today's program. I thank Dr. Manjusha ma'am as well as other members of Women's Committee for helping us, giving us good young speakers from their respective zones and organizing today's program. Thank you all of you. Thank you all the EBs, OBs of MahaIP for joining and giving their full support. Thank you to Pallavi ma'am for giving their digital support. Last not the least, all the attendees on Zoom as well as YouTube Live. Requesting everyone to please join our next Tuesday Take on 18th of July. Thank you and good night.
Good night.
Good night.
Meeting end kara, madam.